Hello and welcome to July's edition of the LLR LMC monthly podcast. This month I'll be mainly concentrating on the long-awaited 10-year plan, but before then I'll just sort of cover some other bits of information. First thing I want to kick off with is the Gala Awards evening, which will be at the end of the year, but we are looking for nominations. So we're looking for the GP who has made the greatest positive impact on general practice in LLR over the last year. Now we're wanting you to put forward someone who has been beavering away in their practice, in their area, has been going well above the usual, has been implementing changes that has really helped your practice to run more efficiently, more better, or has helped your population. So thinking caps on. We want a lot of choice. So we want to know about all the good things that are being done out there by GPs. The closing date is Monday, the 28th of July. So please put that in your diary and please get thinking and get nominating. We held our board meeting this month. Andrew Furlong attended from the from UHR, as well as one of their emergency department doctors. Now we had a long issue about the interface problems that we keep getting told about from constituents with ED, and Dr. Scott Knapp has agreed to go away and to think about those and to come back to us, hopefully to continue to build on sort of joint understanding, joint appreciation, and improving their processes, so it doesn't seem so much that they just sort of dumping on general practice. Andrew Furlong discussed recent change to the Nerve Centre Patient Democratic Service. As we mentioned before, that this is crucial to allow UHL then to develop new clinical services like a proper electronic patient record, but also things like it's needed for them to do a electronic prescribing module. There have been a few sort of minor issues. We don't quite understand all of them, and there might be some odd things that happen that no one's predicted. So if something happens in your practice that you think might be related to the change in the PDS, then please let the MC know, and we can feed that onto UHL, and they can look into it. We also talked about communication strategy. So one of our board members, Dr. Ibrahim Muller, has written a really comprehensive communication strategy, looking at what's in place at the moment and looking how we can change things in the future. So we'll be coming to all constituents when we get this more in place. It's not sort of undoing anything that we've done really, but it's trying to build on what we've got to make it more effective and make sure that we are engaging everyone. Quite sadly, it was Dr. Praveen De Silva's last meeting with us. He's been our resident doctor representative for the last couple of years, and he was the first to be elected through our new system. So currently we are going through an election process. So we have had 3 nominations put forward, and this will be the first election that we are going to use STV for, a single transferable vote, rather than just a sort of first past the post. We were asked about this during our last sort of more wide election for GP board members, and I'm hoping that it will prove to be popular. But this is our first try, so wish us luck and keep your fingers crossed. The LMC website has been up and running for a while now. Lots of positive feedback. I mean, I notice every now and again broken links and missing pages, missing documents. I'm sure you are too. The people who are hosting it for us are trying to sort these out. But if you spot any problems, if you spot any issues with it, then please let the office know. so we can get them solved. And the other thing is that if you're trying to look at particular guidance is not on there, again, let the office know, and if necessary, we can find that and put it up there or write some. Death processes. Big thank you to all practices across LLR. I think, sort of comparing with colleagues around the country, we actually managed to embed the change to the new medical examiner service from last September with fewer problems than elsewhere. We still get the occasional niggly things. If you're using an admin person to send on the information to the ME service, can you please actually just ask them just to check through that the MCCD has been completed correctly. Some of the things that are often done, in fact, even the ME service doesn't always spot, is things like putting the cause of death, which should be in Part 2 under 1D. That seems to be quite a recurrent thing at the moment. Not dated yet or not signed yet, where it says address, just put home address rather than the patient's full address. It needs to be the full address. So if you can just sort of check through that, and also checking that the right thing's been, that there has been something indicated regarding pregnancy, and whether there's an occupational health association. So thank you for that. There's also a new person in the ME office called Tony. He's an MEO, a medical examiner officer. Now his role is to try and keep the office running smoothly. So from time to time he will be contacting practice, basically trying to get information if it's missing or to try and smooth things out if possible. So again, sort of watch out for him. He's a very polite chap and very nice chap. I've met him. The next thing to talk about is, I suppose it's always a difficult thing, is board remuneration, because we are a board of a limited company, and so we are responsible for deciding what we pay ourselves. Now, a few years ago, before I became chair, we actually had appointed an external panel to look at what we were being paid, and they came up with some recommendations that have not been changed since. I mean, since then, first off is that I have tried to rationalise everything. So we basically got two numbers only, which is a sessional rate, which we use mainly for executive members, and an hourly rate that we use for board members doing ad hoc work. And we also pay that to people outside of the board when we ask them to do work on behalf of the LMC. Now, they have been paid at £15,000 a session and £90 per hour. Now, I thought it's important that we try and increase in line with cost of living, and also put in place a method to keep it up to date without having to sort of reconsider it every time. What, of course, this doesn't do is that what we haven't done is we haven't looked at weighting between different roles. So should my role be paid at a higher rate than say, the treasurer role? I mean, it's paid for a different time, but it's not paid for a different rate. We're not doing anything like that with this. I mean, that would be a different job for a different day. This is purely about saying, once we've agreed to the amounts, then how do we keep it up to date? And just to reassure everyone, I'm not looking for an otherwise pay increase. I'm not applied for that. I've not asked the board for that. And I don't intend to do so while I remain in post. So we looked at different methods, and we wanted something which was easy to use. And the one that we've come up with as our preferred option is to use the Bank of England inflation calculator. So you can put in what you were earning and what year that was, and it will tell you what you should be earning now for it to be the same amount. And so what we're proposing is that we use that both for a catch-up for what we should be paying members now, and for in future, so we can keep members being paid at appropriate rates. We're asking constituents to let us know if they have a problem with that. It's set out in much more detail in the newsletter, so please let us know. My proposal is that if there isn't any problem, is that we implement it from the 1st of August. I do not intend to backdate it, so it won't be backdated to the 1st of April. It will only be from August going forward. The next sort of more smaller thing is about Pharmacy First. There has been a problem noticed in that, due to the way it's set out on where the pharmacy fill it in, apparently it's easy to incorrectly code patients as pregnant when they are not. Now, for practices where they're downloading this, where it's coming in say, in electronic form, but as a standalone document, hopefully that they would have picked up on these errors before, and it won't have been coded. But the main issue has been because under the GP Connect service, once you've got that turned on, things like this will be directly loaded into your record. So unless you're doubly checking on why on earth would you go through opening your records to randomly to try and find out whether somebody written something wrong, then incorrect data will have been written to the record. And of course, with pregnancy, that can affect all sorts of other issues, particularly prescribing comes to mind. So be vigilant for that. But to me, this has only affected about 16,000 patients apparently countrywide. But to me, more importantly, this shows the issue of other bodies being able to directly write into our records. And also, we'll be coming to in a minute, the government's bright idea of a single patient record. This is being dealt with nationally. I am aware that almost 2 years ago, the Joint GP IT Committee, which I did chair in the dim and distant past for a while, and was deputy chair for an awful lot longer than that. So about 2 years ago, they actually wrote to NHS England to point out the risk of the way that Pharmacy First has been put together, and similar other data collecting programs, and the high risk of error, which of course is going to relate to patient safety issues. These things, again, I'm getting ahead of myself, but these things are going to be so important if the government gets its way about having a single patient record. So moving on. Now, there are lots of people who have commented already about the NHS 10-year plan. Again, within the document, I've put some links to various resources written by other people. There's a podcast by Katie Bramall-Stainer. If you don't look at any other, please listen to that. That's also listed under our podcast bit. There's also, I've put a link to the BMA a response, the Royal College of GP's response, King's Fund's response, GP Online podcast about it, and Pulse Today. Both those are interesting because they are GP focused, but they look at it not without the GP optics, but optics from someone outside of general practice. The report runs to 168 pages, and I've read it. I was going to say I've read it, so you don't have to. But actually, I would suggest that you at least glance through it and read the important bits. The plan, like the curate's egg, is good in parts and not so good in others. So first thing to say is that there is a huge risk to general practice within this plan. General practice has continued in its basic form of being a list-based, holistic, providing holistic longitudinal care with continuity to a registered list of patients, really since the National Insurance Act of 1911, which established panel doctors, as an aside, also local medical committees. Indeed, I've been at meetings where I've heard general practice being referred to as a cockroach of NHS healthcare, because it doesn't matter what's thrown at it, it seems to continue to survive. There's been lots of tries to change the way general practice works, but none of them have stuck so far, but this is the risk. Now, this comes following the report by Lord Darcy, and then the 3 shifts that the government announced, shifting from hospital to community, shifting from analog to digital, and shifting from sickness to prevention. In my document, you'll see that I've actually divided the my thoughts into the good, the bad, and the ugly. And then I've added 2 extra ones. I never knew that. A few interesting factoids. And last one was, what were you sniffing, Wes? Because really bits of this does sound like someone was having a bad trip when they wrote it. So good. It talks about decommissioning of poorly performing providers. Now, you might think that seems a bit odd, why I put that in as being good, but one of the issues has been is that while general practice has constantly been knocked if they're poorly performing, this has never happened, or rather hasn't happened for a long time, for hospitals. Now, when I worked in Regional Health Authority and as executive, which was back in 1990, we did close down units. In fact, we did close down hospitals who were so badly performing that they could not be turned around. And when the patient safety issue was such that we had no option. But that, as far as I'm aware, has not happened since. So this will be a positive thing, because this actually will sort of try and make secondary care, rather than bumbling on, actually pull their fingers out. Now, if you can think about services like maternity services, where they have been lambasted across the whole of the UK for poorly performing. Now, actually, there's good reason for that. Things like sort of being poorly led and being poorly funded. Now, I know that our local maternity service has done a lot to try and get that house in order, but really, these departments shouldn't be allowed to get like that, and hospitals should be enabled to be able to speak up. They're not able to, because you and I know, and I've said this many occasions before, that the NHS runs on a top-down bullying process. No other way of putting that. Cahill formula, at last, a promise that the Cahill formula will be replaced. Now, this has been looked at on I think, at least 3 occasions before since its invention, because it is well out of date. It was using data that was available at the time and the limited data that was there, and thus doesn't do what it's supposed to. And the problem in the past has been that when it's been looked at, they didn't want to change the money in the envelope, which meant that there was going to be as many losers as winners. Now, I'm hoping that if combined with increased funding within general practice, they will be able to implement a revised Cahill formula by using new monies, so it won't be taking monies away from any particular practice. As far as I'm concerned, there is no such thing as an overfunded practice or even a well-funded practice. We have just got poorly funded practices and excruciatingly badly funded practices. A new area for general practice. The plan recognises that the current patient dissatisfaction with GP services. It promises increased capacity with thousands more GPs, a reduction in bureaucracy and rollout of AI technology, including AI scribes. It promises that those who need it will get a digital or telephone consultation the same day. Maybe that's not so good. But of course, what it misses, what this doesn't say, is that what this will need is significant increased funding and massive investment in GP premises before this can be able to go ahead. The plan recognises the significant importance of public health and social factors in health, like education and work and all those things, and having a good diet. It does propose a Start for Life programme for communities, and it refers to the Tobaccos and Vapes Bill, which when passed will mean that children turning 16 this year will never legally be sold tobacco. And I suppose take place some interest with a past public health background. These things are fantastic to hear. Improve support for rollout and implementation of new technologies. Of course, this must be done. We've been left with a complete mess with AI scribes because practice just won't get on and use this stuff, and the centre just cannot get their head around it, and localities don't want to be the first one that does it. They don't want to be put themselves in the firing line. In fact, all we've had so far is a rather nannish guide from NHS England, and then a letter from the National CCIO, which felt like it was just telling us all off. Development of the NHS app to be a single portal to hold patient information for them to be able to see all the information. So hopefully that will get rid of the need for SARS as being a minimum improvement, ability for them to book and to check on appointments, which again will take sort of loads off us if they can see what's happening with referrals to secondary care. When the NHS app was dampened, it was planned that they were going to do all these things, but I met them as being part of the BMA team, in fact, as being the then deputy co-chair of the joint GPITC, I think, at the moment. When I met their team, they all looked about the age of 12, which probably meant that even at that time I was probably old, and we had to go through with them line by line what was feasible and what wasn't, which is why it's been opened, which was why it was sort of launched with a much smaller set of abilities, and why it's been gradually being built on. The other part of this, of course, last month I raised the fact that TPP have decided they can do what they like with the NHS app and not sort of do what the centre wants. So the centre's got to be able to mandate suppliers to ensure that any NHS app, regardless of what systems, clinical systems are being used, displays the information exactly the same way. Genomics. Again, this could be in more than one part of what's good or bad and the ugly. But I think overall this is good. Genomics of both newborns and of adults. Over time, this will allow us to better target preventative medicine and also treatments, which hopefully will reduce over medication and over investigation, whilst being more effective. Cherry picking. They state that they will no longer tolerate cherry picking are the gaming by independent providers. You may know this, I'm positive I've mentioned this before in the newsletter, that independent providers, when they take on NHS contracts, they receive the same money as the NHS, but then they cherry pick patients that are fit and well and won't cause them problems. Power. Now, this says that power is going to be pushed out to local systems of providers, which again will be a good thing in developing services and maintaining services. But sure as eggs at first, negative daily fail or other headline, I expect that will be quickly clawed back in, probably by the time of the next election. So I will predict that next election, expect power to be drawn back into the centre if it hasn't done before then. CQC, the plan envisages that future CQC visits will be determined by the outcome of AI-driven data. I think actually this is positive. As I've said over and over again, you cannot inspect quality into a service, but using these sort of dashboards to pick practices that may be failing and going along to them at an earlier stage, and then going through the data with them, understanding what's happening, and then hopefully together with the ICB helping to turn the practice around before they become truly failing is much better than what happens now when they turn up, find a practice which is really failing, go to the court and get it turned and get it closed down that day, not even the following day. And the only downside is that they also plan to continue routine inspections every 3 to 5 years. And as I said, that actually does not make sense. And I'm hoping that once a new system is embedded, that they will phase out the routine visits, because there'll be no need for them whatsoever. They also promised to complete before mandatory training reduce yet, and I would give the plea. First thing to shine the light on is the Oliver McGowan training, which is over the top, and I like every other GP I've spoken to, found the course not to be helpful. Sorry about that, people provide it, but it isn't. Medical trainees are getting an overhaul. They said they'll learn from the Leng review about introducing other staff groups to clinical teams. And they say that they're also going to prioritise UK medical graduates for foundation year posts and prioritise medical graduates together with other doctors who've been in the NHS for a significant period for specialist training posts. The only problem I've got with this is if they go ahead with their idea about apprenticeships. I think that's appalling for medicine. I don't know what you think. please let me know. Not least because many other countries, and Portugal was in the vanguard of this, saying that if the UK adopted that approach to medical training, then they would no longer recognise GMC registration as being proof of being a doctor if someone wanted to go and work in their country. Single national formulary, again, a good idea to move away from local formularies where our experience locally has been that drugs tend to change around the reg rating because of enthusiasm of particular specialists in the hospital. And at times, even they admit that they want it purely to make it more convenient for their service. Well, general practice isn't there to make things convenient for you, but they are there to provide patient safety and high quality care. A review of the clinical negligence claims process, which again is long overdue. Having experienced this process from both sides, it only appears to work for the lawyers. I hope, I don't think we'll get it, but I hope that there might even be adoption of a no-fault compensation scheme like that in current use in New Zealand. And you may be surprised to know that there are sort of specialty-based similar schemes even in the USA. I remember talking to a Texan orthopedic surgeon many years ago when we still paid our own indemnity, and was absolutely shocked to find that him, as being an American orthopedic surgeon, was paying less in indemnity each year than I was as a GP. And it wasn't because I was paying well above colleague, because I was paying the standard rate, but it was actually because they had one of these processes in place. Right, now moving on to the bad. Now the bad, first off, is that this is extremely light on general practice. Now I thought general practice would be in here. You know, it's a general practice is a body that provides 90% of healthcare for 6% of the budget. The Darcy report said how hard done by the general practice has been and how general practice needs to be, have much better investment and transfer of funds and all that. So what did I find? I find minimal. Indeed, it actually tars the whole of the NHS with the same brush in many areas. So when reading it, I found myself shouting at the screen, oh no, again, this is not in general practice's name. One example is that it repeatedly refers to productivity and productivity plummeting without any recognition that that does apply to hospitals, but it does not apply to general practice, where even Wes is on record recognising that productivity in general practice has increased. So why on earth couldn't you actually just recognise it in this plan? Well, of course, it's because they don't like general practice. I'll just whisper that to you. They hate general practice. Contracts for neighbourhood providers. Again, you think, moving on from PCNs and the old neighbourhoods, having to proper neighbourhood providers with their own funding to be able to provide local services. What could go wrong? Loads. First off, is that we've actually already got neighbourhood providers. We call them general practices, and all you need to do, Wes, is to invest in general practice, and we can provide everything that you want to do without inventing yet another tier. The other problem about this is that they want these neighbourhood providers perhaps to be run by other bodies. Potentially, I'll come back to this a bit later on, by UHL, by the acute trusts, and that they will hold general practice contracts. So general practices that are failing and general practices that want to choose, they will take over their contracts. The fact that I'll come back to, I think, that bit in a bit. And then, of course, the concept of neighbourhood centres. So actually turning these providers into centres where actually physically where patients go. Actually, patients want to go to their local GP practice. They don't want to trudge up the road to somewhere else, wherever they don't have to. But they will have to if that's where general practices are relocated to. You may remember that Alan Milburn had this bright idea before about Darcy centres, which failed. It failed because then, like now, they don't understand general practice, they don't understand patient wants, and they weren't willing to invest the significant, massive amounts of money needed to pump prime them. So again, recycling, a bad idea which has failed before. Why? Moving on to the ugly. Now, in the ugly, I kick off with a single patient record. Maybe, of course, because of my IT background, but this to me would kill, I think, general practice. I can see why it's attractive to politicians and to patients and to managers, of course, and this isn't the first time round it came. There was previous governments that have liked this. There was a chap, I don't know if you remember him, called Tony Blair, who was persuaded to have this. Apparently sitting on the sofa with this SPAD, who persuaded him within half an hour that one, they should have a national programme for IT, which wasted between 6.4 and 30 billion, depending on whose figures you look at, but also said that there was going to be a single patient record, which also died. Why don't I like it? For lots of reasons, and I set them out in more in full, but basically curation. Who on earth is going to look after this record? If it's nobody's requirement, then nobody's going to do it. Okay, and GPs are not going to want to try and curate a record where everyone in their dog are writing into it. It's just not possible. Quality payments. If we can continue with the QOF, IF, or anything like that, we need it to be based on our data, not random stuff that other people have written. And this is coming back to what I've already talked about the problem with Pharmacy First. These things are going to happen over and over again. We don't want to lose out on performance money because some other practice has written incorrect codes into our system, confidentiality. Once patients know that everything they tell the GP will be open to be seen by every other body, including the department, including social services, including even places like the Home Office. You may remember that there was a memorandum of understanding signed between the NHS and the Home Office to share patient data with them. Yeah, we've been there, we've done that. I don't think it's any surprise that Palantir have been chosen because, of course, they've done that sort of matching data in other countries. Data control and medical legal issues. Unified record would require the state of data controller to move out from general practice. I cannot be the data controller of stuff which is not my data. And of course, where it's been discussed before, it's always been thought that this would move to the Secretary of State. Now, I know that many practices have been wanting to lose data control status, but actually I want to retain ownership and control of the data of my patients in my practice. I do not want others having the constant ability to change, update, delete data. Whilst I presume there will still be an audit trail, when a patient and others look at it, they'll assume what's in the record is the truth, the whole truth, and nothing but the truth. But in the future, it wouldn't be. Woods for trees. I mean, those that suffer with with System 1, which is a system, I'll be honest with you, I don't like. Know that all you need is a patient who's under the care of local district nurses or whoever, or the community services, to make it at times really difficult to work out what's going on. The filters don't work properly to just be able to see what the information on what you want. But if you add to that a patient who's in and out of hospital, having ITUs, strict stays, trying to look at sort of long-term sort of trends for things like EGFR, even something as simple as that, will be nigh on impossible. And everything that I've above will reduce patient safety. So if anyone asks you why there isn't a single patient record, say because it's a nuts idea. It's an ugly idea. Now, a lot of what Wes says he wants can be achieved by having improved interoperability and improved share of data. So there is the local health and care record, of which we have a one up and live in LLR, which allows you to see data from other services. At the moment, it's hospital and GP data. I'm not quite sure whether LPT data has come on board, but also long term there will also be social services data. So there is a way of being able to look at this information without having a single patient record as a single unity. Patient power payments. The concept that patients can determine how much you are paid probably looks good from patient's point of view, but actually not for general practice. Okay, so do you really want your income to be determined upon whether Bill from down the road liked his last appointment? No, that last appointment where we refused to give him a sick note because he was going on holiday and didn't want to lose his benefits for a month, where you refused him more benzodiazepines, you refused to increase his opiates, for which he no longer has a good clinical reason to be on, etc., etc. Refused to treat his dental problem, refused to prescribe antibiotics for his dental abscess, all those things. Do you want these patients to be determining how much funding your practice gets and through that how much you take home in your pocket? I mean, for hospitals, if they lose a bit of funding, it makes it a bit tight for them, but it doesn't actually mean the chief exec goes home with less money. It doesn't mean that the consultant and the nurse that dealt with that patient goes home with less money. Maybe we should propose that. Maybe we should say, yeah, we love patient power payments, but how about it comes out of all of the staff's pockets the same as it would do for GP partners. Selling patient data. I suppose, at least we should give them this, because they're upfront in it. Where's this upfront? We're going to sell your data. Now, it says anonymized data, and it actually says they will gain commercial value, but we all know that means selling. This is a bit different from, I suppose, care.data times, when that program were saying in public that they were refusing, that they would not be selling data, whilst at the same time there was a price list that they put together and they were circulating to possible buyers. Now, someone very close actually was leaked a copy of the price list by a civil servant and then went on to share that important information with a few choice journalists. The other thing about care.data is anonymized, which is what this talks about again. And they published it. And using a jigsaw approach, IT people were able to work out individual patient records, including that of Tony Blair, because they knew of a procedure they had, and they knew that date that had been done because that had been in the press. They knew his date of birth, and they knew a couple of other factors about his health and family. And so by putting that information in, they were then able to identify his whole record. They also were able to locate the record for the wife of the deputy prime minister at the time as well. Now, the ability of to protect data using software has improved since those days, but I'd want to be reassured that these data was being protected really properly, and in preference, I'd like Palantir to have no place anywhere near it. I never knew that. Right, a few little factoids that I found were quite interesting. I wasn't aware that a quarter of the population now have more than one long-term health condition, and between them they account for 65% of NHS spending. Although, of course, we are aware in LLR from local data that the number of patients with multiple long-term conditions increased by 40% since 2019. Second, the plan actually says that there are approximately 1.5 million people in England purchasing privately Mounjaro or Ozempic. So that's 2.2% of the adult population are buying these drugs. Wow, just wow. I can understand why a few of my colleagues have jumped on the bandwagon and are now using private companies to sell this stuff. They must be making a mint. And good luck to them. We all know that excessive alcohol consumption is harmful, but were you aware that the estimated societal cost of alcohol harm is 27.4 billion per year? That's 1.2% of the GDP goes on paying for the harmful effects of alcohol. 4% of the population drink 30% of the total alcohol consumed each year. Again, startling facts, and maybe more interesting to me with my public health background, but wow, just wow. Last thing, what were you sniffing, Wes, when you wrote this bit? So, I've only got a few things in here. So, yeah, honest. So first thing, integrated health organisation. So this is one of the most interesting ideas that what they're saying is that foundation trusts, if they're running really well, could become an integrated health organisation, and they would have the budget for everyone. So they have the budget for the acute trust, for general practice, for dentists, for opticians, for community services, and they would hold it. So, it does actually say in the plan that it could be held by a GP, but as I say in my newsletter, I'm more likely to be elected as the next Dalai Lama for that to actually occur in reality. But I think there must be a huge pushback that if this gets anywhere near the statute book, that the majority of board members must be GPs. GPs providing 90% of healthcare. They must have the majority say in any such organisation. The plan says that they've based these on HMOs in the USA. Of course, the USA is a health system notorious for universality of care, delivering primary medical health services and cost effectiveness. But another way of putting it is that they are looking to transfer 90% of healthcare from what they have already accepted are the most nimble, cost-effective, most highly productive part of the NHS. They're going to transfer that across to the most uncost-effective, always in deficit part of the NHS, which has seen their productivity plummet, which they've not been able to turn around yet. This seems such a good idea. Not. The other thing, just to say, is that this was done before, not including general practice, but when NHS Trusts, before Foundation Trust days, when NHS Trust came into existence following the 1990 Act, I was around in NHS management from 92, 93 time onwards, is that the initial trust was set up often combining acute services with mental health and community services into one trust. Within a few years, it became very obvious that the black hole of the acute trust, which is just a financial black hole, just sucks in everything around it, did that, and they asset stripped and they ripped money out of mental health services and community services. And folks, that's the reason why mental health services still have never made it back to the levels of funding they had before 1990. That's because of this policy was so bad. So it became, within a few years, they had to strip these bodies apart. However, we're not going to learn, but we're going to do the same thing again and pretend this time we're going to get a different result. I like that one as well. Foundation Trust, again, so this is another bright idea from the 2003 Community Health and Standards Act, which created these. It was one of Alan Milburn's bright ideas before, or just as an aside, I know I keep going around in circles, but the draft version of the NHS plan apparently had a final chapter written by Alan Milburn, basically setting out how this would all be implemented, but that has disappeared. I'm not sure whether this is just association with his name or whether what was written in there they realised was, again, would have ended up in my "what were you sniffing" column. I'm not sure. Anyway, so this is bright idea in 2002, implemented in 2003, and Foundation Trust had to show that they were balancing the books, in fact, having a bit left over so they could invest in their own capital. But of course, they can't do that. Hospitals can't do that. So what happened was they turned to saving money wherever they could. And the biggest spend within any hospital is staffing. And so they cut back on staffing. Many hospitals did this. Only one came to the front, and that was Mid-Stas. And I remember I was working in management in the West Midlands around this time, and so heard more about what actually happened, I suppose, in general. But this was a disaster. So this created one of the biggest patient safety scandals in the NHS. There were other trusts that were very similar, but they didn't come to the forefront. And the problem was spotted, and Foundation Trust's programme cured before many more patients came to harm. So again, we're taking an idea which didn't work before, and we're going to have another go at it. Well done, Wes. The plan claims that 2/3 of hospital outpatient appointments can be replaced by automated information, digital advice, direct input from specialists, and patient-initiated follow-ups. Well, I'm totally agreement that hospitals have much to learn from dental practice about how to be more efficient in terms of using technology. And in fact, general practice could go a bit further embracing technology. The reality is that nowhere near reduce outpatients by 2/3. What this does, as we know, is that it makes life better for us, it makes life better for the patient, but it doesn't save swathes of time. And if it does, it just saves on admin reception time. It does not save on clinical time. So again, where on earth are you getting these figures for? The plan complains that everything in the NHS is 9 to 5. First, of course, that this is an insult to our colleagues, or an insult to every GP, because we don't work 9 to 5, but an insult to our GPs, particularly who work in out of hours, and every hospital which provides 24 hours a day, 7 days a week healthcare. Second, actually, patients don't want healthcare out of hours. We do extended hours, so I do them in evenings, at the weekend. And one of the common things is, why on earth are you phoning at this time, doc? Or why on earth are you, are you breaking up my weekend? I'm down the pub, I'm watching the footy. Please just sort of let me be. So patients don't want it. It doesn't help. Most healthcare can occur during normal office hours. Why on earth are you wanting to break that? Why on earth are you wanting to increase the cost base? Because it's what it will do for what really very few people actually want. So the plan has got a lot about technology in it. A lot of it seems sensible, but it sort of lulls into this false sense of security. It comes out, funnily enough, with a wonderful statement. And this is a direct quote: as digital access becomes a norm, many patients will get instant access to a clinician, removing the need to wait for advice or care. Instant access to a clinician. Now, I would love to be so over-resourced that I give a GP sitting in a cupboard waiting to be that instant access. That ain't going to occur. Of course it isn't going to occur. We know it's not going to occur. They know it's not going to occur. And the only instant access I have to my bank, which of course they keep referring to, is to a little artificial intelligence character in the corner that seems never to understand what I say or what I want, and then says, you've now got to wait for an operator, and I sit there for half an hour waiting for a real person. Perhaps when he's saying that he wants it to be like banks, that's actually saying, that's what we need. So anyway, so that's the what we use sniffy bit. So in summary, much to be good about it, but much to be harmful, particularly bad for general practice in what it doesn't say and also what it does say. So what it doesn't do is it doesn't say anything about the promised new general practice contract that we're expecting within this parliament to reimagine and rebuild on general practice. And the other thing is that this potentially brings in a route to the death of general practice if it rolls out. Now, as I've said, we've had many things like this before, and they have all failed because actually what the centre finds over time is trying to provide general practice any other way than using the partnership model costs more for a normally lower quality service. So if you meet your MP, if you meet your councillors, if you meet your PPG, tell them about this. Tell them about why the NHS plan is bad. Tell them about, lots of good things in it, but can they please revisit how it's going to affect general practice? I based my final thoughts on this 10-year plan as well. And just to sort of read you my last paragraph, whereas your vision will also kill the concept of the family doctor that you say you want patients to experience, and kill the benefit of continuity of care that has been repeatedly proven to provide the highest quality, lowest cost healthcare. Your big idea is set to fail and will never work, as you have done nothing in this plan to engage those of us who provide 90% of NHS healthcare for 6% of the budget. This is a shame, as there are many good ideas in the 10-year plan that should be implemented. On that note, I'm going to sign off, and I hope that next month I can be a little bit more positive. So see you then. And of course, I would love any feedback. Tell me if I misread this. Tell me if I've been reading the wrong one. Tell me if you agree. But just let me know. Always available. Email grant.ingrams@llrlmc.co.uk. Drop me your thoughts. Thank you. Right.